Welcome to another in-depth session of the Deep Dive. Today we're embarking on a truly comprehensive journey into the core mechanics of human lactation. Think of this as your ultimate shortcut to becoming profoundly well-informed, meticulously crafted for anyone preparing for high-standard certification exams, especially the International Board Certified Lactation Consultant, or IBCLC exam. Our mission is to give you a complete IBCLC exam-level overview of mammary development, breast anatomy, and physiology, drawing directly from a stack of authoritative sources. We've pulled out the critical knowledge and some surprising facts, too, aiming to help you not just learn, but truly master this intricate and vital subject.
That's absolutely right. For anyone involved in lactation support, understanding the foundational what and the crucial why behind these biological constructs isn't just, academic knowledge. It's really the bedrock of evidence-based, compassionate care. When you truly grasp these intricate details, you're empowered to spot patterns that others might miss, connect seemingly disparate pieces of information, and encourage a deeper level of critical thinking in every real-world scenario you encounter. This deep dive is designed to equip you with that very skill set.
Okay, let's unpack this then. We're going to begin at the very foundation, the physical structure of the breast itself. What are its fundamental components, and how do they lay the groundwork for milk production?
Right. To really understand how human milk is made and delivered, we need to zoom in, starting really at the cellular level and building our way up. The very basic secretory units of the mature glandular tissue in the breast are called the alveoli. You can imagine them as tiny grape-like clusters, or maybe miniature factories, nestled within the breast. This is where the magic happens. These are the acinar units where milk is actually synthesized. Now here's a crucial detail. Each cluster of these secretory cells within an alveolus isn't just floating freely. It's enveloped by a specialized contractile unit, the myoepithelial cells. Think of these like a tiny muscular net surrounding each grape, if you will. They're absolutely essential because their contraction is what physically squeezes the milk out of the alveoli during a letdown, pushing it forward. Without these, milk would simply stay put.
So once these microscopic factors, the alveoli, produce the milk, how does it then exit the breast and make its way to the baby? It's through a complex network of ducts, isn't it?
Precisely. From those tiny alveoli, the freshly synthesized milk moves into even tinier tubes called ductules. These ductules then merge together, like small streams joining to form larger rivers, creating progressively bigger ducts. It's a common misconception, one you'll often hear, that these ducts widen into large sinuses or reservoirs right behind the nipple. But our sources clarify that isn't quite accurate. Instead, the ducts are actually highly distensible.
Distensible, meaning they can stretch.
Exactly. They have elastic walls that can expand significantly as they fill with milk during the milk ejection process. They swell with milk, ready for release. On the very surface of the nipple, you'll typically find about 9 to 10 distinct duct openings, often referred to simply as nipple pores, which is where the milk finally emerges.
And what about the internal lining of these ducts? Is it consistent throughout, or does it change depending on where you are in the system?
That's a great question, and it really speaks to the breast's clever design. Near the nipple, where there's potentially more wear and tear, the ducts are lined with stratified squamous epithelium. You can think of this as a tougher, multi-layered protective lining, quite similar to, say, the skin on your outer body, designed for resilience. But as you move deeper into the breast, further from the nipple, this lining cleverly transitions to columnar epithelium, which is a more delicate, single-layered lining. This shift is fascinating because this inner lining is optimized for both secreting and absorbing various milk components. It's remarkably specialized for its different functions. And all of this intricate network, the alveoli, ductules, and ducts, is beautifully supported by highly vascular connective tissue. This tissue is rich in blood vessels, ensuring a constant supply of nutrients and hormones. Within this connective tissue, we find the important Cooper's ligaments.
Ah, yes, Cooper's ligaments. I've heard of those.
Right, they're the suspensory ligaments of the breast. These fibrous bands extend from the deep fascia, which is connective tissue covering muscles, up to the skin. They provide crucial structural support, helping to prevent excessive sagging and defining the breast's overall shape.
That's a really detailed picture of the internal architecture. But what about the overall breast size and weight? How does that change throughout the lactation journey? And maybe more importantly, does breast size actually matter for milk production? It's a question a lot of new parents and even some healthcare providers ponder.
It's a fascinating area, and you're right, it comes up a lot. The answer isn't as simple as bigger is better. The average non-lactating breast weighs about 150 to 200 grams.
Yeah.
But here's where it gets really interesting. During lactation, that weight nearly doubles. increasing to approximately 400 to 500 grams, which is roughly 1 pound.
Wow, that's a significant increase.
It really is. It indicates the sheer amount of glandular tissue development and increased blood flow involved in milk production. You might also notice, and this is important clinically, that breast size can naturally decrease again between 6 and 9 months postpartum, even if breastfeeding continues effectively. This doesn't mean milk supply is dropping. It often reflects the breast becoming more efficient and less, generally engorged as lactation matures. And yes, breast size can factor in, but not always in the way people assume. We know breast asymmetry is very common.
Right, one breast being larger than the other.
Exactly, with the left breast often being slightly larger than the right. This is usually just a cosmetic variation and doesn't typically impact milk production potential. However, marked asymmetry or clear breast hypoplasia, which means significant underdevelopment of the glandular tissue in one or both breasts, can indeed be an indicator of potential problems with milk production. It's not about the overall cup size or the amount of fatty tissue. It's specifically about having enough active glandular tissue to produce a full milk supply. So if you see significant noticeable asymmetry, it's definitely a cue to assess for the sufficiency of that glandular tissue.
Fascinating. So knowing all these intricate internal structures and how size changes, what about the sensory network? How does the breast feel? Are there specific nerve connections that are absolutely crucial for a mother's sensation and for the whole breastfeeding process?
You've hit on a critical point there. The wiring of the breast, the nerve supply, is incredibly important, not just for sensation, but for triggering physiological responses like milk ejection. The breast's nerve supply originates from the 2nd to the 6th intercostal nerves, which are nerves running between the ribs. But the one to really pay close attention to, the sort of VIP nerve, if you will, is the 4th intercostal nerve. This nerve is crucial because it supplies the greatest amount of sensation to the nipple and areola, which are highly sensitive areas vital for the suckling reflex. For the left breast, this nerve typically penetrates the breast tissue at the 4 to 5 o'clock position, and for the right breast, it's usually at the 7 to 8 o'clock position.
That's specific. Wow.
Yes, and clinically, this anatomical detail is incredibly vital. For instance, if the lowermost branch of this 4th intercostal nerve is severed, which can sometimes happen during certain breast surgeries like reduction mammoplasty, it can lead to a significant, sometimes permanent, loss of sensation to the nipple and areola. This loss of sensation can, in turn, impede the mother's ability to feel the baby's latch effectively and can even interfere with the milk ejection reflex, making breastfeeding much more challenging.
So we've covered the mature breast structure, the stage being set. But now let's pull back the curtain on the incredible unseen symphony of physiology that truly brings this amazing system to life. The actual making of milk. What's the very first note in that symphony, the foundational growth story that gets the breast ready for lactation even before birth?
Well, that foundational growth story is called mammogenesis. It basically refers to the overall mammary, or breast, growth, including increases in both the size and weight of the breast tissue. This process isn't just a single event. It unfolds throughout a woman's life, especially during puberty and then quite dramatically during pregnancy. During these key developmental phases, the breasts undergo significant architectural changes. This involves the extensive proliferation of both the ducts, those milk-carrying tubes we just discussed, and the glandular system, which includes the alveoli. This growth is primarily driven by the crucial influence of 2 hormones, estrogen and progesterone.
Okay, so what does each one do specifically?
Good question. Estrogen, for example, is largely responsible for the proliferation, the branching out of the ductal system. Think of it like building the plumbing. While progesterone primarily stimulates the development of the glandular tissue itself, preparing the alveoli, the milk-making units. Then, specifically during pregnancy, as the body prepares for actual milk production, the alveolar cells undergo further development and differentiation. This final preparatory phase is influenced heavily by prolactin, which primes these cells to become efficient milk factories. It's truly a beautifully orchestrated, multi-stage preparatory process. It ensures the breast is fully capable of lactation by the time the baby arrives.
Now, let's zoom in even closer on the nipple and areola. These are the baby's direct interface with the breast, the critical point of connection. What are the common characteristics and variations we see there, and how might these impact the breastfeeding journey?
The nipple and areola have quite a bit of natural variation, and understanding these can be really helpful for clinical practice, especially for IBCLC exam prep. First, color variation is completely normal and simply aligns with a person's overall complexion, It ranges from pink to tan in individuals with fairer skin to brown or even black in women with more melanin. It's just a natural part of human diversity. Then we have supernumerary nipples, also known as accessory nipples. These occur in about 1% to 5% of the population.
So extra nipples.
Exactly. They're essentially extra nipples that form anywhere along what's called the embryonic milk line, a ridge that runs from the armpit down to the groin during development. Our sources even cite a fascinating case report of a woman who developed multiple galactosales, which are milk-filled cysts, in her axillae or armpits. These were believed to be linked to this accessory breast tissue located outside the main breast area. It highlights that milk-producing tissue isn't always confined to the primary breast mound.
That's quite a variation. What about issues like nipple shape, or whether it protrudes easily? We hear a lot about flat or inverted nipples causing challenges.
That's a really important practical consideration. Poor nipple protractility, where the nipple doesn't easily extend or protrude when stimulated, perhaps by cold or touch, is observed in about 10% to 35% of women, particularly during their first pregnancy. Closely related is nipple inversion, which affects about 3% of women. In a large majority of these cases, around 87%, is bilateral, meaning both nipples are inverted. And interestingly, only about 4% of inverted nipples are truly tethered or tightly bound by adhesions that prevent them from ever protruding. The vast majority can be encouraged to protrude with gentle manipulation or interventions. From a hormonal perspective, it's interesting to note that prolactin specifically influences nipple growth and development, helping it to become more prominent. In contrast, the overall increase in breast volume due to areolar growth during pregnancy is more directly related to serum placental lactogen, another pregnancy hormone which prepares the entire breast for milk storage.
So, if a woman has inverted or poorly protractile nipples, which can certainly make latching challenging initially, are there clinical interventions that can truly help facilitate successful breastfeeding?
Absolutely. And early interventions can make a real difference, forming a key part of IBCLC practice. For inverted or flat nipples, breast shells can be quite effective. These are soft, dome-shaped devices worn inside the bra, perhaps prenatally for increasing periods, sometimes up to 8 hours a day, and then removed at night. The gentle, constant pressure they apply around the nipple base is thought to help gradually release those underlying adhesions, promoting nipple elongation and protrusion. Our sources indicate that consistent use of breast shells can significantly enhance a woman's ability to achieve and maintain exclusive breastfeeding. It's a non-invasive way to physically encourage nipple protraction and prepare it for the baby's latch.
Okay, now that we've laid the groundwork on breast anatomy and development, let's shift to the truly amazing physiological process of milk production itself. When does milk production actually begin? You mentioned prolactin primes the cells during pregnancy, but is actual milk being made then?
Yes, absolutely. It's not just a switch that flips at birth. The journey truly begins much earlier, in a stage we call lactogenesis, stage I. This initial phase of milk synthesis begins remarkably early, typically from mid-pregnancy, and continues all the way through late pregnancy. During this stage, the mammary secretory epithelial cells, or lactocytes, those incredible milk-making cells, begin to differentiate and transform into fully functional secretory cells. It's prolactin, that key hormone released from the anterior pituitary gland, that primarily stimulates these cells to start producing the fundamental components of milk: protein, lipid, and lactose. It's essentially early colostrum. What's truly astounding is that by this point in pregnancy, 4 of the 5 necessary pathways for milk secretion are already synchronized within these alveolar cells. They're essentially priming the entire production line.
So the factory's built and the machines are humming, just waiting for the go signal.
Exactly. The 5th pathway, the paracellular pathway, is still open at this stage, allowing some substances like sodium and chloride to pass between cells, which contributes to the specific composition of early colostrum. So the breast is literally getting ready for its big moment, preparing its entire metabolic machinery long before the baby ever makes its grand entrance.
And then after birth, there's that dramatic moment often called the milk coming in, or the milk transition. What exactly is happening on a physiological level during that crucial transition from small amounts of colostrum to copious milk production?
That dramatic shift is lactogenesis, stage 2, also known as secretory activation. It typically occurs between day 3 and day 8 postpartum, though there's some individual variation, of course. The fundamental trigger for this stage is a rapid and significant drop in maternal serum progesterone levels immediately following the delivery of the placenta. During pregnancy, progesterone, while vital for maintaining the pregnancy itself, acts as an inhibitor, keeping large-scale milk production in check. Once the placenta is delivered and progesterone levels plummet, that inhibitory effect is removed, allowing prolactin to fully unleash its milk-producing power on the prepared breast tissue. On a cellular level, a really key event defining this stage is the closure of tight junctions between the alveolar cells.
The sealing the system idea we touched on.
Precisely. Before lactogenesis II, in those first few days, there are larger, more permeable gaps between these cells, forming that paracellular pathway, allowing things like immunoglobulins to pass easily into colostrum. But during lactogenesis II, these gaps are sealed by gasket-like protein complexes, which ensures that substances are now directed through the cells rather than simply passing between them for proper, controlled milk synthesis.
So it's like the breast's milk production line goes from being a bit leaky, allowing big immune factors through, to a fully sealed, high-efficiency system, ensuring precise composition for mature milk.
Exactly. This crucial cellular sealing, combined with the removal of progesterone's inhibitory effect, leads to that rapid increase in milk volume. It's typically observed anywhere between 38 and 98 hours postpartum, followed by an abrupt leveling off as supply begins to regulate. Accompanying this volume surge are significant and characteristic changes in milk composition. You'll see a notable decline in breast milk levels of sodium, chloride, and protein, and a reciprocal rise in lactose and milk lipids as the milk truly matures into its full, nutrient-dense form. Mothers often describe the physical sensations of lactogenesis II as a feeling of fullness, warmth, and sometimes a tingling sensation in their breasts, a clear sign that the milk is coming in. This stage also marks a critical shift in how milk production is regulated. It moves from primarily endocrine control hormone driven from afar to autocrine control.
Meaning local control within the breast itself.
Yes, the breast itself starts regulating milk production based on how much milk is removed. It's a beautifully efficient feedback loop kicking in.
That transition sounds incredibly vital for establishing supply. Given its importance, what factors can interfere with or delay this critical milk coming in phase, potentially causing problems for both mother and baby?
Lactogenesis 2C is indeed quite, you could say, fragile and susceptible to outside influences, and recognizing these potential delays is absolutely key for an IBCLC. Several factors can significantly delay its onset. For instance, extensive maternal-infant separation in the immediate postpartum period, or late initiation of milk removal from the breast, meaning the baby isn't put to breast or milk isn't expressed early enough, frequently enough, can interfere with the necessary hormonal signals and the establishment of that autocrine control. Also, certain maternal metabolic derangements can play a significant role. Conditions like persistently high breast milk sodium levels, particularly on or before day 3 postpartum, are a big red flag.
Why is high sodium a problem?
Because it indicates those tight junctions haven't closed properly. It signals impending breastfeeding problems and can even lead to mammary involution, where the milk-making tissue starts to shut down if milk isn't effectively removed. Other hormonal disturbances, such as high testosterone levels in women with conditions like polycystic ovary syndrome, PCOS, or complications from insulin-dependent diabetes mellitus, can directly delay or even suppress lactogenesis. It truly highlights how interconnected these biological systems are and how many variables can impact this crucial stage.
Okay, so once milk production is established and flowing, how is it maintained and regulated for the ongoing needs of the baby? What keeps the supply going day after day, week after week?
That's where galactopoiesis comes in. This is the prolonged phase dedicated to the maintenance of established milk secretion. Fundamentally, it's controlled by that elegant autocrine or supply and demand system we just mentioned.
The more you remove, the more you make.
That's the simplest way to put it, yes. The more milk that is removed from the breast, whether by the baby suckling or by expressing, the more the breast produces. This is a critical concept for lactation consultants to explain. Frequent and thorough breast emptying actively stimulates the development of more lactocytes, our milk-making cells, and also upregulates hormone receptors on existing cells, thereby enhancing the breast's capacity to produce milk. Think of it like a factory that gets more efficient and produces more the more you clear out its finished product. Conversely, if milk isn't regularly removed, a buildup of inhibiting peptides in the full breast signals the breast to decrease milk secretion. It's a brilliant self-regulating mechanism. Interestingly, about 1/3 of the milk available in the breast typically remains as residual milk volume even after a feeding, but this still usually exceeds the baby's typical daily intake. And while breasts grow significantly during lactation, their physical size might decrease between 6 and 9 months postpartum, even with continued effective breastfeeding, because they've become so efficient.
Let's dive deeper into the key players in this hormonal orchestra. Prolactin and oxytocin. We know they're essential, but how do these two hormones specifically orchestrate milk production and release? And what are some of their fascinating nuances?
They are truly the superstars of lactation, each with distinct but complementary roles. First, prolactin, which comes from the anterior pituitary gland. It's the primary hormone that stimulates the mammary secretory epithelial cells, our lactocytes, to actually produce the milk. What's particularly fascinating about prolactin is that its levels follow a distinct circadian rhythm. Levels are noticeably higher during the night, especially during sleep.
Which is why those night feeds are so important, right?
Exactly. Your body is naturally primed for higher prolactin surges then, making those feeds critical for establishing and maintaining a robust milk supply. Prolactin levels do decline slowly over the course of lactation, but here's a key takeaway for long-term breastfeeding. They remain elevated for as long as the mother breastfeeds, even for years. This isn't just a biological detail. It's a profound insight into nature's commitment to sustained feeding.
So the baby suckling directly impacts prolactin levels. Is there a magic number of feeds to maintain supply?
Absolutely. Suckling is the direct activator.
Yeah.
Prolactin levels significantly rise with suckling. And the more frequent the feeding, specifically our sources tell us more than 8 breastfeedings per 24 hours, the more it helps prevent the concentration of prolactin from declining too much before the next feed. It's about keeping that signal strong and consistent. We even know that feeding 2 babies simultaneously, like with twins, can actually double the prolactin surge. Now, it's important to clarify a nuance. Once lactation is well established, prolactin levels are not necessarily directly proportional to the total milk yield. While essential for the process of production, the amount of milk produced also heavily depends on the efficiency and thoroughness of milk removal that autocrine control. Prolactin also plays a significant role in delaying the return of ovulation by inhibiting the ovarian response to follicle-stimulating hormone, FSH. That's the basis for lactational amenorrhea. You'll often see higher prolactin levels in amenorrheic women. Interestingly, prolactin isn't related to the degree of postpartum breast engorgement, and external factors can surprisingly affect it. Prolactin levels actually drop with cigarette smoking, rise with beer drinking.
Beer drinking.
Really?
Yeah.
Yes, though obviously not recommended as a strategy. And levels also rise with anxiety and psychological stress. Interestingly, mothers experiencing depression may even exhibit lower serum prolactin levels, which can sometimes impact supply. For interventions, drugs like bromocriptine and cabergoline are well known to suppress prolactin levels in lactation, often used in specific clinical scenarios like maternal HIV or stillbirth if needed. Conversely, dopamine antagonists like metoclopramide, Reglan, and domperidone, Mutilium, are sometimes used, often off-label, to stimulate milk production by inhibiting dopamine, which normally suppresses prolactin.
And the other half of this powerful duo, oxytocin, we know it's responsible for the letdown, but what's happening at a deeper level, and what does that feel like for the mother?
Right, oxytocin, released from the posterior pituitary, is truly the key to the milk ejection reflex, often called the letdown. In response to infant suckling, or even sometimes just thinking about the baby, oxytocin causes the contraction of those myoepithelial cells we talked about earlier, the tiny muscular nets surrounding the alveoli. This contraction physically forces the milk from the alveoli into the ducts, making it readily available to the newborn through the nipple openings. Oxytocin isn't released as a steady stream. It comes in distinct pulsatile ways, traveling through the bloodstream to the breast. Many women describe feeling a distinct pressure, tingling, or warm sensation during a letdown, a clear physical manifestation of this hormone at work.
I've heard that described often.
Yes, and you can even observe a significant measurable increase in milk duct diameter via ultrasound imaging when the milk ejection is sensed. Once lactation is established, it's very common for women to experience multiple milk ejections during a single feed, though they often only sense the initial, most intense one. This pulsed release ensures efficient milk transfer throughout the feeding. And importantly, the release of oxytocin during feeding is associated with a calming, often sleepy effect for the mother, a wonderful natural benefit that aids in bonding and relaxation. It's like a built-in neurohormonal reward system.
Now that we've delved into the incredible maternal physiology, let's turn our attention to the infant. The baby's mouth is remarkably adapted for breastfeeding, almost like a perfect little machine. What are the key anatomical features that make it so effective?
The infant's oral anatomy is truly a marvel of evolutionary adaptation for breastfeeding. Let's start with the hard palate, the roof of the mouth. Unlike an adult's deeply arched palate, an infant's is typically short, wide, and only slightly arched at birth. This flatter, wider shape creates more space for the breast tissue during feeding. Crucially, it is corrugated transverse folds called rugae on the anterior part right behind the gums. These rugae are vital.
Like little ridges.
Exactly, like tiny ridges. They help the newborn hold the breast securely during sucking, providing friction and grip, almost like tread on a tire. It works in concert with the tongue to stabilize the nipple within the mouth. Then there's the soft palate, that muscular flap at the back of the roof of the mouth. This flap performs a critical dual function. It seals to the back of the tongue during sucking to create that essential negative pressure needed for milk extraction, forming a vacuum. And then it elevates to seal off the nasal cavity during swallowing, preventing aspiration of milk into the airways. It's a remarkably precise and automatic movement.
What about the cheeks and tongue, which seems so active during feeding?
Those are equally critical. The infant has prominent buccal pads, which are dense fat pads in the cheeks. In full-term newborns, these are adequately developed and are absolutely essential for assisting in the creation of negative pressure. They prevent the cheeks from collapsing inward, maintaining that vacuum needed for effective suckling at the breast. Preterm or malnourished infants might have underdeveloped buccal pads, making suckling much harder. The tongue itself is typically pink and moist, and for effective feeding, it should protrude symmetrically over the alveolar ridge, the gum line, when the mouth is open, fitting easily within the mouth when closed. Any abnormalities like macroglossia, an abnormally large tongue, or micropnathia, an underdeveloped jaw, can profoundly impact feeding mechanics. It's also worth noting that breastfed infants demonstrate better coordination between swallowing and breathing, which actively helps to prevent subclinical aspiration, where tiny amounts of liquid enter the airway. And typically, newborns are nose breathers due to the positioning of their soft palate and the relatively high position of the larynx. While infants can mouth breathe if necessary, nasal occlusion can quickly cause ventilatory problems, especially during feeding.
It's a complex, highly coordinated dance. How does this suckling reflex develop, and what does effective suckling actually look like in action from the baby's perspective?
It truly is a marvelous dance, and it begins surprisingly early. The suckle reflex, one of the foundational reflexes for feeding, can be observed in fetuses by just 24 weeks gestation. That's incredibly early. By 28 weeks, preterm babies can actually start to coordinate the suckle-swallow-breathe cycle, which is a major milestone for their feeding independence. And by 32 weeks, they can even sustain repeated bursts of more than 10 suckles, with maximum bursts exceeding 30. This early development sets the stage for what happens soon after birth. In the early postpartum period, especially within the first 2 hours, healthy full-term newborns are typically in a state of alert behavior, a first period of reactivity, which is ideal for that crucial first feeding. They'll show instinctive rooting, licking, nuzzling, and hand-to-mouth movements, leading to a spontaneous latch and suckling. A little-known fact, but quite helpful in practice. Leaving the amniotic fluid on the baby's hands after birth can actually help them find the breast, leveraging their innate olfactory senses.
Like a scent trail.
Exactly. It provides a familiar scent cue. And skin-to-skin contact is equally effective as supplemental heat in maintaining the baby's temperature, plus it facilitates these early feeding behaviors.
So what's the perfect or optimal latch for all of this coordinated movement to happen effectively and efficiently?
For an optimal latch, the baby needs to open their mouth wide, what we call the gape, with the tongue positioned low at the bottom of the mouth, ready to catch the nipple and areola. The nipple should be aimed towards the baby's soft palate, not the hard palate. This ensures a deep, comfortable latch that avoids nipple compression. Once latched, the baby's lips should be flanged outward, like fish lips, creating a wide seal, and their nose should be slightly away from the breast surface to ensure easy breathing. Our sources indicate the nipple tip should rest deeply in the baby's mouth and can move an average of 4 millimeters anterior of the hard palate-soft palate junction, with the tongue cupping around the nipple. This full frontal contact for the baby allows for efficient milk transfer and minimizes pain for the mother. The suck-swallow-breathe pattern, while complex, becomes natural and rhythmic for most full-term infants. For low birth weight babies, fatigue can be common, so pacing feeds by briefly removing the nipple to allow breathing breaks, or, for breastfeeding, applying gentle pressure on the breast to occlude ducts during periods of overly rapid milk flow can be helpful. We also know that higher suckling rates, what we call non-nutritive suckling, often quick, shallow sucks, tend to occur with decreased milk flow, and conversely, milk flows fastest during the downward motion of the baby's jaw during nutritive sucking.
Despite all these natural adaptations and optimal mechanics, sometimes babies struggle. What are some common problems that prevent effective suckling, and what are the clinical implications we should be aware of?
This is where the IBCLC's detective work often begins, you're right. When infants frequently attempt to breastfeed but fail to effectively remove milk, it's most often due to an improper latch or a suckling abnormality. This creates a vicious cycle. It leads to pain for the mother, insufficient milk intake for the infant, and can ultimately compromise the mother's milk production due to inadequate emptying. One significant structural issue we often see is tongue tie, or ankyloclasia, caused by a short or tight lingual frenulum, that band of tissue under the tongue. This can restrict the tongue's movement, leading to a weak suck, lack of effective tongue movement, poor lip seal, and an inability to generate adequate suction or keep the breast in the mouth. While frenotomy, or frenuloplasty, a simple surgical procedure to release the frenulum, can be controversial in some circles, it's often a remarkably successful treatment for pronounced cases that are clearly impacting feeding.
So, nipple trauma for the mother can also be directly caused by the baby's oral anatomy, even if the latch seems okay from the outside.
Yes, absolutely. Nipple trauma and pain for the mother can be directly linked to subtle variations in the infant's oral anatomy. For example, a baby with a high or bubble-shaped palate, or a mother with very large or fibrous nipples that don't fit well into the baby's mouth can cause friction, compression, and damage. Even an optimally positioned but retracted or inverted nipple can rub on the baby's palate during suckling, causing significant pain. Another significant challenge is oral motor dysfunction, often due to neurological impairment. Any deficit affecting the baby's neuromuscular function like hypotonia or low muscle tone carries a risk of feeding difficulties. This is because the intricate coordination of suckling, swallowing, and breathing is integrated under medullary or brainstem control.
Right.
Signs of hypotonia often include a weak suck, poor lip seal, inability to generate adequate suction, or difficulty keeping the breast inside the oral cavity. In these cases, supportive techniques like specific positioning, for example, the clutch hold, semi-elevated side lying, or prone on a reclined mother, providing consistent head and breast support and ensuring easy milk flow can be incredibly helpful. Sometimes, a nipple shield can provide a firmer, more dramatic stimulus to the baby's mouth to help organize the suck. What about more significant anatomical challenges like a cleft lip or palate? How do those impact breastfeeding and what specialized support is needed? Infants born with a cleft lip and palate, CLP, often face significant suckling difficulties due to their inability to create proper suction, making effective milk transfer extremely challenging. Management often involves a multidisciplinary team. For feeding, this can include specialized feeding bottles that are flexible and squeezable, like the Mead-Johnson or Haberman feeders, which allow the caregiver to assist milk flow. Sometimes, obturators, custom-made devices that cover the palatal defect, are used to improve suction. Crucially, ensuring continued milk expression by the mother is vital for maintaining her supply, even if the baby isn't effectively feeding at the breast initially. And finally, for infants with cystic fibrosis, CF, breastfeeding is particularly beneficial. Human milk contains significantly greater amounts of lipase than cow's milk, an enzyme that aids fat digestion.
That makes sense.
Yes, this can actually help breastfed infants with CF absorb fat more efficiently, which is a major nutritional challenge for them. Nutritional management for CF-affected breastfed infants involves promoting breastfeeding, providing fat-soluble vitamin supplements, pancreatic enzyme replacement, and often salt supplementation, especially in hot weather or with fluid loss due to their unique electrolyte imbalances.
Okay, let's shift gears to the milk itself. Human milk is truly a powerhouse of nutrition and protection. It's more than just food. It's a dynamic living substance. Let's really break down its key components, starting with the fundamental building blocks, the macronutrients and micronutrients.
Indeed, it's an incredibly complex and dynamic fluid. The macronutrients protein, lipid, fat, and lactose are all brilliantly synthesized and secreted by those specialized mammary secretory epithelial cells, the lactocytes, directly in the breast. Let's talk about protein first. Mature human milk contains about 0.8 to 0.9 grams of protein per deciliter. It's not just high quality, it's precisely balanced for the infant's needs. And here's a key insight. Some of the protein in human milk also serves crucial immunological purposes, acting as protective agents, not just nutrients. Human milk contains both casein and whey protein. What's fascinating is that their ratio changes throughout lactation to meet the baby's evolving needs.
How does it change?
Well, for instance, it's about 90.9 whey to casein in early lactation, favoring the easily digestible whey. Then it shifts to around 60.4 in mature milk and balances closer to 50.50 in late lactation. This dynamic ratio is important because whey proteins form soft, easily digestible curds in the baby's stomach, making it gentle on their immature digestive system. That's unlike the tougher, less digestible curds formed primarily by casein, which is the dominant protein in bovine milk.
And the fat content, which is such a critical energy source for babies, what makes that so special and variable in human milk?
The lipid, or fat content, is particularly interesting because it's the component of human milk that is most affected by the mother's food intake. It also increases more steeply as more milk is taken from the breast during a single feeding. This means the milk at the end of a feeding, often called hind milk, is generally richer in fat than the fore milk at the beginning. This variability allows for a brilliant natural feedback system. Baby-led feedings can actually help infants regulate their fat intake by determining how long they feed and how much of the breast is emptied. Fats are a highly concentrated energy source, providing a whopping 9 kilocalories per gram compared to 4 for protein and carbs, making them vital for rapid infant growth. They also carry essential fat-soluble vitamins A, D, E, and K, and critical essential fatty acids like docosahexaenoic acid or DHA.
Right, DHA for brain development.
Exactly, crucial for infant brain and eye development. A surprising fact is that GHA levels can often be low in typical American women's diets, so a recommended intake of 300 mg for lactating women is suggested to ensure adequate levels in their breast milk for the baby's optimal development.
And what about the main carbohydrate in human milk?
That's lactose. It's the principal carbohydrate in human milk, making up about 4% of colostrum and rising to about 7% in mature milk. It metabolizes into glucose, providing essential energy, and galactose, which assists in lipid deposition in the brain, another vital component for neurological development. Lactose also plays a crucial role in enhancing calcium absorption in the infant's gut and inhibiting pathogen growth, contributing to a healthy gut microbiome. As for micronutrients, the concentrations of several essential ones, including vitamins A, B6, B12, C, D, and K, as well as thiamine, riboflavin, choline, selenium, and iodine, are influenced by the mother's nutritional status and intake. This highlights the importance of maternal diet. The American Academy of Pediatrics, AAP for example, specifically recommends 400 international units, IU, of vitamin D per day for all breastfed infants from birth, as human milk levels alone may not be sufficient. Human colostrum is also particularly rich in vitamin E, or tocopherol, which acts as a powerful antioxidant, protecting delicate cell membranes in the baby's retina and lungs. And zinc is actively transported into the mammary gland, with its levels peaking on the second day postpartum before gradually declining over the duration of lactation.
Beyond just basic nutrition, human milk is teeming with dynamic, biologically active components. This is where it truly transcends simple food. What are these incredible bioactive factors that offer such profound protection?
This is where human milk truly distinguishes itself and becomes so much more than just a nutrient source. It's a living fluid. It contains vast amounts of beneficial bacteria or probiotics, including species like Staphylococcus, Streptococcus, Lactobacillus, and Bifidobacterium species. The maternal microbiome is literally transferred to the infant through the milk, profoundly impacting their gut health, immune system development, and overall well-being. For example, certain Lactobacillus strains actively compete with pathogenic microbes and can significantly ameliorate the symptoms of rotavirus infections, a common cause of infant diarrhea. Then there are the oligosaccharides.
Those complex sugars, right?
Exactly. Complex carbohydrates, of which there are over 130 different types. They are many times more abundant in human milk than in bovine milk or any formula. Think of them as nature's tiny, vigilant bouncers for the baby's gut. Their crucial role is to literally block antigens from attaching to the epithelium of the gastrointestinal tract. They prevent pathogen attachment, such as for pneumococcus, a common cause of ear infections and pneumonia. The insight here is that human milk isn't just food. It's an active, sophisticated immune shield, custom designed to block invaders right at the entrance.
That's incredible, like a personalized defense system delivered with every feed. What other bioactive factors contribute to this unique protective power?
It's truly a biological marvel. We also find insulin-like growth factor, IGFI, which has a significant growth-promoting role. Its concentration in colostrum is astonishingly high, about 30 times that in human serum, and significantly higher than what you'd find in cow's milk or formula, highlighting its importance in early infant development. Beyond these, human milk contains a symphony of other bioactive components. Lactoferrin, an iron-binding protein with antimicrobial properties. Lysozyme, an enzyme that breaks down bacterial cell walls. Various cytokines, which are cell-signaling proteins that regulate immune responses. Numerous growth factors that promote tissue development. Other enzymes that aid digestion. powerful antioxidants that protect cells from damage, and a wealth of cellular components like white blood cells, which all contribute significantly to human milk's protective effects, especially for our most vulnerable, the preterm infants. Even an enzyme like lactoperoxidase, though in low levels in milk itself, is substantially present in newborn saliva, and the IgA in milk actually enhances its ability to kill streptococci, showcasing another amazing synergistic protective mechanism.
This brings us to where human milk truly shines. Its unparalleled ability to protect against and even prevent illness. How does it provide such robust immunological protection, both immediate and long-lasting?
It's a multifaceted defense system, much more intricate than just passive antibody transfer. First, there's a crucial distinction between the body's overall systemic immune system and the secretory immune system, which acts locally on body surfaces like the breast and gut. Here's a surprising fact. Lymphocytes, a type of white blood cell, become sensitized to antigens, pathogens, in the mother's environment, say in her gut or respiratory tract. These sensitized lymphocytes then travel through her bloodstream and migrate specifically to the breast, where they secrete immunoglobulins, particularly secretory IgA, SAGA, directly into the milk.
So it's targeted protection.
Highly targeted. It provides protection against the very pathogens the infant is most likely to encounter in their immediate environment. It's like a personalized immune update delivered with every feeding.
So it's not just passive immunity from antibodies that cross the placenta before birth, but an active ongoing shield created in response to the mother's exposures.
Exactly. While passive immunity from maternal antibodies transferred through the placenta is important, breastfeeding can also confer active immunity by stimulating the infant's own immune response. For instance, enhanced vaccine responses are consistently seen in breastfed infants, demonstrating their developing immune systems are being primed and learning effectively. And here's a truly fascinating example. If a mother is immunized with attenuated viruses, like the rubella vaccine virus, it can appear in her milk lymphocytes. Her infant may then transiently show antibodies without actually developing the illness, effectively receiving a form of natural immunization boost. Specific T cells and B cells also transfer via human milk, further enhancing the baby's immune repertoire.
That's truly incredible that it can actively help the baby build its own immunity and protect against so many conditions. What about protection against specific infections and chronic diseases? The list seems quite long.
The protection is truly profound and dose-dependent, meaning exclusive breastfeeding consistently offers greater protection against a wide range of issues. We see significantly decreased rates of infections like gastroenteritis and diarrhea, respiratory illnesses including RSV, even in the presence of environmental tobacco smoke and otitis media, or chronic ear infections. The benefits extend far beyond infancy into childhood and adulthood, offering protection against chronic diseases such as celiac disease, type 1 and type 2 diabetes, and multiple sclerosis. It also significantly reduces the risk of sudden infant death syndrome, SIDs. Our sources also point to potential protection against certain childhood cancers, like Hodgkin's disease.
No, cancer too.
Yes, possibly linked to a human alpha-lactalbumin protein lipid complex called Hamlet, which has been shown in labs to induce apoptosis-like death in tumor cells. Breastfeeding is also associated with a lower incidence of allergies and atopic diseases like eczema, food allergies, and respiratory allergies throughout childhood and adolescence, particularly when breastfeeding is prolonged. A key mechanism here is that the infant intestinal mucosa is highly permeable to proteins before 6 to 9 months, and the secretory IgA in human milk helps to paint the intestinal lining and bind sensitizing proteins, reducing allergic reactions. Beyond disease prevention, breastfeeding profoundly impacts oral development. Artificial feedings can alter normal early oral cavity development, potentially leading to later problems like malocclusion, improper bite. Breastfed children tend to have fewer issues, developing well-rounded, U-shaped dental arches, which in turn can mean fewer snoring and sleep apnea problems later in life.
Okay, let's bridge all this amazing science to the practice. For any aspiring IBCLC, understanding how to establish and maintain a robust milk supply is absolutely crucial. What are the pivotal first steps and ongoing strategies for ensuring adequate milk production?
You're right, this is the cornerstone of clinical lactation support. The foundation of a robust milk supply is built on early initiation and frequent feeding. Our sources consistently show that initiating breastfeeding within the first hour or two after birth significantly increases milk production down the line. This early, consistent milk removal fundamentally calibrates production, setting the stage for future supply. Increasing the number of feedings on days 2 and 3 postpartum further boosts supply. Here's a critical, often overlooked fact. If milk is not effectively removed by day 3 postpartum, mammary involution, the process of the glandular tissue reverting to its non-lactating state begins. This can jeopardize long-term supply. Exclusively breastfed-term infants typically feed a median of 8 times per day, often with very frequent cluster feeds in the early weeks.
So parents shouldn't worry if the baby seems to want to feed constantly at first.
Exactly. It's important to reassure parents that constant feeding or hourly feeding in the early weeks is physiologically normal and necessary. Expecting babies to sleep alone or go for long stretches can be counterproductive to establishing supply.
So it really comes down to that fundamental principle of supply and demand, doesn't it? Driving production through removal.
Yes, exactly. Abundant, ongoing milk production absolutely depends on frequent and thorough removal of milk from the breast, whether that's by the infant suckling, hand expression, or pumping. The breast adjusts its production to meet the infant's needs, usually settling into a more predictable pattern by about 6 weeks postpartum, at which point that autocrine, local control, really takes over. If a mother is experiencing low supply, there are concrete, evidence-based strategies to help. These include applying moist heat to breasts a few minutes before feeding, gently massaging breasts before and during feeding or pumping, and using relaxation techniques, as stress can sometimes inhibit letdown. Most importantly, feeding the baby and/or expressing milk at least 8 times every 24 hours and continuing that frequent removal, even if initial amounts are small, is vital for signaling the breast to produce more. Hand expression and hands-on pumping techniques, where you massage the breast while pumping, are also incredibly effective at increasing milk volume and fat content. In some specific cases, a synthetic oxytocin nasal spray can be prescribed to help elicit the milk ejection reflex and reduce pumping time, although it doesn't necessarily increase total milk volume on its own.
And when it comes to pumping, which is so common now for working mothers or those with preterm infants, how can they maximize their efficiency? Getting the most milk possible in the least amount of time is often the goal.
Pumping efficiency is absolutely key. For many mothers, you're right. Double pumping, meaning pumping both breasts simultaneously, is significantly more efficient than single pumping. It yields maximum milk volume in less time, typically 7 to 12 minutes, compared to 10 to 15 minutes for single pumping. This is because it creates a more powerful and sustained hormonal signal for both prolactin and oxytocin. Eliciting the milk ejection reflex, MER, before applying the pump is also crucial.
How can they do that?
Things like having the baby suckle briefly on one breast first, looking at a picture or video of the baby, listening to soothing music, or practicing deep, calming chest breathing can all help trigger it. Interestingly, fuller breasts tend to achieve MER faster. Additionally, using relaxation techniques, employing visual imagery of milk flowing, applying warm, moist heat to the breasts before and during pumping, and ensuring correct flange size, the part that fits over the nipple, are all important contributors to maximizing milk yield and comfort. Pumping after a feeding or pumping the opposite to breast while nursing can also help stimulate flow. And here's that crucial mechanical understanding again. A breast pump doesn't suck milk out. Rather, it reduces resistance to milk outflow from the alveoli, allowing the internal pressure of the breast to push the milk out. This principle was pioneered by Einar Egnell, based on meticulous dairy industry research, and his design still influences modern pumps.
Okay, even with the best foundations and techniques, challenges are an inevitable part of the breastfeeding journey for many. How do we effectively manage common issues like breast engorgement and nipple pain, which can be so debilitating?
You're right, these are incredibly common and can absolutely derail breastfeeding if not managed promptly and effectively. Breast engorgement, when severe, is a painful, often pathological condition. It typically results from mismanagement and milk stasis, meaning milk isn't being removed adequately. It's often more intense in multiparous women who've breastfed before. Common causes include supplemental feedings, which reduce breast stimulation, delayed initiation of breastfeeding, infrequent or poor feedings, or time-limited feedings.
It's like switching breasts too soon.
Exactly. Removing the baby too soon from the first breast to ensure feeding from both, which leads to incomplete emptying. Certain breast surgeries like implants or lumpectomy can also contribute. The best prevention for engorgement is immediate breastfeeding within the first hour after birth and frequent effective milk removal thereafter. This is why rooming in and demand feeding are so vital. Treatment involves expressing or pumping milk just enough to relieve pressure and soften the breast for latch, and addressing any associated edema, often with cold compresses between feeds.
What about the equally distressing issue of nipple pain or trauma, which can make every feeding agonizing?
Nipple pain and trauma can be truly debilitating, and it's often the reason women stop breastfeeding early. If it's early onset pain, meaning it starts right at the beginning, it's almost always mechanical. It's related to an improper infant latch or suck, or excessive nipple stretching or compression by the baby's mouth, or even a poorly fitting pump flange. The very first strategy is always to remove the baby from the breast gently and try again with a different technique or position. Correcting the latch is paramount. A persistently painful latch always needs further investigation into infant sucking problems. Pain that is sudden onset after previously comfortable feeding often signals an infection, either bacterial or yeast, thrush. It's important to know that most topical remedies, commercial creams, ointments, antiseptics, even traditional remedies like tea bags or food-based oils, are often ineffective or even potentially harmful, with some link to increased mastitis risk.
So most creams don't really help healing.
Clinical research largely shows they don't improve healing outcomes, no. While purified lanolin might provide some comfort as a moisture barrier, randomized trials haven't definitively shown it improves healing compared to just air drying or using expressed breast milk. Applying warm water, however, can provide genuine relief for some types of pain, like vasospasm.
And if there's a suspicion of infection, particularly thrush, which sounds notoriously painful,
For issues like candidiasis or thrush, which presents with symptoms like intense redness, itching, sometimes tiny ulcers on the nipple, and areola resembling chickenpox, and extreme deep burning or shooting pain, it's crucial to understand it as a family disease. It spreads quickly and requires a referral, often a culture to confirm, and most importantly, simultaneous treatment of the baby's mouth and diaper area, the mother's breasts, nipples and areola, and potentially her sexual partner, as they can also carry the yeast. Pacifiers and bottle nipples can also harbor this infection and should be replaced or boiled rigorously and frequently to prevent reinfection. Lastly, a crucial caution for any IBCLC. Any persistent red, scaly, cracked nipples resembling eczema that are slow to resolve or don't resolve with typical treatment should prompt evaluation for Paget's disease, a rare but serious type of breast cancer that can mimic benign skin conditions. Always refer for medical evaluation if something doesn't look right or isn't improving.
right, always err on the side of caution. Beyond the mother's experience and these challenges, how do we assess and support the baby's unique needs during breastfeeding? An IBCLC needs to assess the baby just as much as the mother.
Absolutely. Assessing the infant is equally paramount. First and foremost, we encourage parents to observe the baby, not the clock, to determine feeding cues and satiety. This is a fundamental principle of responsive feeding. Early cues that a baby is hungry include wiggling, moving arms and legs, rooting, turning their head and opening their mouth when their cheek is stroked, and putting their fingers or fist to their mouth. Mid-cues involve fussing or making squeaky noises. Crying is actually a late cue of hunger.
So you want to feed them before they start crying, ideally.
Ideally, yes. Feeding at the earliest signs reduces infant stress and often leads to a more effective feed. Satiety cues, indicating the baby is full, include the baby ceasing active suckling, falling asleep at the breast, relaxing their body, or releasing the breast spontaneously. Then, stooling patterns provide a predictable indicator of milk intake and gut health. Newborns typically transition from thick, black, tarry meconium in the first few days, to greenish-brown transitional stools, and then to yellow, very soft or liquid stools by day 4, 4, 5, passed 3 to 5 times a day, with a characteristic sweet or yeasty odor. The fecal flora of breastfed babies is dominated by beneficial lactobacilli and bifidobacteria, differing significantly from formula-fed infants.
And weight gain, which is often a significant concern for new parents and a key metric for lactation consultants. How should we track that?
Normal weight gain for breastfed infants is about 10 grams per kilogram per day, or roughly 5 to 7 ounces per week, until about 4 weeks postpartum. After that, it naturally slows to about 1 gram per kilogram per day by the end of the first year. Interestingly, exclusively breastfed infants may have the same or slightly greater weight gain for the first 3-4 months, but then often way less than bottle-fed infants between 6 and 20 months, even though their length and head circumference track similarly. This subtly suggests that formula-fed infants may sometimes be overfed compared to the natural regulation seen in breastfeeding. Hypoglycemia or low blood sugar is a significant concern, particularly for infants of diabetic mothers, post-mature, premature, or small for gestational age, SGA infants. Hypoglycemia is generally defined as a serum glucose concentration of less than 30 mg/dL in the first 24 hours, or less than 40 mg/dL after 24 hours. Prevention is absolutely key.
What helps prevent it?
Immediate skin-to-skin contact, unrestricted access to the breast for early colostrum intake, maintaining warmth, delaying bathing, delaying cord clamping, and avoiding separation all play crucial roles in stabilizing the newborn's blood sugar.
And what about pacifiers and infant crying, which are often sources of debate or anxiety for parents? How do these fit into optimal breastfeeding support?
The World Health Organization, WHO, and UNICEF actively discourage pacifier use for breastfed infants, particularly in the early weeks, while supply is being established. This is because significant use is associated with shorter breastfeeding duration and less exclusive breastfeeding. While it may sometimes be more of a marker of underlying breastfeeding difficulties or reduced maternal motivation than a direct cause of early weaning, pacifier use can reduce the baby's total time suckling at the breast, which directly impacts milk supply stimulation. As for crying and colic, it's a common misconception that babies just need to cry sometimes. Breastfed babies nursed on cue and held frequently rarely cry for extended periods without a clear need. Crying is a signal of need, whether for food, comfort, warmth, or closeness, and it actually increases the baby's stress levels and releases stress chemicals. Prompt response to crying reduces the baby's stress and significantly enhances parental confidence and bonding. It is truly never appropriate to let a baby cry it out, as this can have detrimental effects.
When things aren't going smoothly, even with the best intentions and knowledge, sometimes extra support or tools are needed to bridge gaps or support the breastfeeding journey. What are some key interventions and devices that an IBCLC might utilize?
This is where practical clinical skills and tools become invaluable. Nipple shields, typically ultra-thin silicone devices, are important tools in certain situations. They create an artificial nipple over the mother's own. They're primarily used to assist and maintain latch-on, especially for complex situations like severe nipple inversion, for low birth weight infants who might struggle to create and maintain suction, or for babies with oral anomalies or upper airway dysfunction that interfere with latch. They can also offer temporary relief for very sore nipples and help manage an overly rapid milk flow.
Weren't there concerns about them reducing milk transfer?
Yes. Earlier, thicker shields did raise concerns about impairing milk removal. However, newer research, especially with the ultra-thin silicone shields, shows they can be remarkably effective for ensuring adequate weight gain and preventing early breastfeeding abandonment when used correctly under guidance. They do require close collaboration with a lactation consultant to ensure adequate milk supply is maintained and that the shield is used appropriately as a temporary tool. Infants may need the shield until approximately their term-corrected age, often a few weeks of use.
And those breast shells we talked about earlier for nipple protraction, do they have other uses postpartum besides that prenatal use?
Yes, breast shells can indeed be beneficial postpartum as well. They can be worn between feedings postpartum to continue encouraging protraction or to protect sore nipples from clothing friction. The gentle, constant pressure they exert around the nipple base is thought to gradually release adhesions, allowing for a more sustained nipple protrusion or elongation. Then there are feeding tube devices, which are incredibly versatile tools used to temporarily assist the baby at the breast while providing supplementation.
Like an SNS system.
Exactly, like a supplemental nursing system or similar device. They allow the baby to suckle at the breast, stimulating supply, while receiving supplemental milk, either expressed breast milk or formula, through a thin tube attached near the nipple. These are useful in situations like adoptive nursing after breast reduction surgery with diagnosed primary lactation insufficiency, or for infants with genetic, anatomical, or neurological problems who struggle with efficient transfer. A major advantage is that the baby controls the flow, reducing the risk of being overwhelmed, and it keeps the feeding experience at the breast. Close follow-up and rigorous cleaning guidelines are mandatory for these devices.
And of course, milk expression is a huge component of lactation support today, whether by hand or pump, for so many different reasons.
Absolutely. While devices for milk removal date back centuries and were historically used mainly to relieve engorgement or for damaged nipples mastitis, today milk expression is common for short-term problem-solving or long-term provision of human milk. This includes situations like preterm birth, maternal employment, maternal illness, or for mothers inducing lactation or relactating. When choosing a pump, mothers often prioritize quick and effective milk removal, comfort, reasonable price, and ease of finding, use, and cleaning. Many now receive pumps as an insurance benefit. A key point is that the pump must be efficient enough to activate both prolactin and oxytocin release. The volume expressed is also directly related to the breast fullness at the time of pumping.
And regarding breast pump use and express milk, what are the critical safety considerations around potential contamination? This seems like a really serious topic, especially with vulnerable infants.
This is indeed a critical area, and one where IBCLCs play a vital role in education. There have been concerning reports of bacterial contamination of breast pumps and expressed milk leading to serious outcomes, including cases of Serratia marcescens and Chronobacter sakazaki, which, in one tragic instance mentioned in our sources, caused significant brain damage in a preterm infant due to contaminated pump parts. It's vital to remember that breast milk itself is not sterile, but proper hygiene with pump parts is paramount.
What are the key guidelines then?
Guidelines for cleaning are crucial. Always use hot, soapy water, ensure thorough rinsing, air dry all parts completely on a clean towel or rack, and properly disassemble all pump parts after each use for cleaning. For storage, fresh unrefrigerated milk should ideally be used within 4 hours. Refrigerated milk is safe for up to 96 hours, 4 days, and if stored longer, it should be frozen. A crucial rule. Thawed milk should never be refrozen, as this can degrade its quality and increase bacterial growth. Finally, donor human milk from screened donors and pasteurized by human milk banks is a safe preferred option when a mother's own milk is insufficient or unavailable and medically needed, especially for ill or high-risk infants. Our sources explicitly discourage informal milk sharing, often found online, due to the complete lack of donor screening and pasteurization, which poses significant unacceptable safety concerns, including disease transmission risks.
Okay, moving beyond the mechanics and interventions, a mother's overall health and lifestyle play a huge role in her ability to breastfeed successfully. Let's explore those interconnected considerations, starting with diet and nutrition.
A mother's well-being is absolutely paramount, influencing both her milk supply and her capacity to cope with the demands of breastfeeding. For maternal diet and nutrition, a well-balanced diet, including proteins, carbohydrates, fats, fruits, vegetables, and grains, generally meets a lactating mother's needs. Her energy requirements are approximately 500 kilocalories per day over her non-pregnant recommended caloric intake.
So, not a huge amount extra, but noticeable.
Right, it represents the energy cost of milk production. She should limit consumption of fish with high mercury levels and, importantly, drink fluids to quench thirst, rather than forcing specific amounts. The body's pretty good at regulating that. Supplementation may be needed for women with chronic illnesses causing nutritional deficiencies or those carrying multiples. Interestingly, while dietary fat content can affect milk fat composition, overall gradual maternal weight loss, about 4 to 5 pounds per month, is safe and generally has no deleterious effect on lactation.
That's good news for mothers wanting to lose baby weight.
Yes, it means it won't decrease milk supply if done gradually. This can be achieved with modest caloric intake reduction and exercise. There's also a transient bone loss among breastfeeding women, around 5% short-term loss, followed by a remarkable recovery within 18 months postpartum, often exceeding the initial loss. Menstrual activity, rather than diet, is a primary factor in bone mass recovery, and for allergens, exclusively breastfed infants can exhibit allergic symptoms from substances ingested by the mother. Common offenders include cow's milk air products, chocolate, cola, corn, citrus fruits, wheat, and peanuts. Maintaining a detailed food diary can help identify specific triggers if needed.
And what about medications? This is a huge area of concern and often a source of anxiety for many new mothers needing treatment for something. What are the general principles for safe medication used during lactation?
It is indeed a major area of concern, and it's critical to provide evidence-based guidance, not just anecdotal advice. The general principles for maternal medications are, first, avoid unnecessary use of any medication. Second, prefer drugs with shorter half-lives, less toxicity, and crucially, poor infant oral bioavailability.
Meaning the baby doesn't absorb much even if it's in the milk?
Exactly. It reduces infant absorption and thus exposure. Always check for available published milk studies using reliable resources like MacMed. If a drug readily enters the central nervous system, CNS, it will likely enter breast milk. Mothers should always be counseled to watch for any changes in milk production or subtle infant side effects like drowsiness or irritability. A relative infant dose, RED, of less than 10% is generally considered compatible with breastfeeding. For specific examples, NSAIDs like ibuprofen and ketorolac are often ideal analgesics due to their very low RED, less than 0.6%. Opioids like morphine can be used short-term post-delivery, but mepridine requires caution due to active metabolites and a prolonged half-life in newborns. Benzodiazepines are generally discouraged due to their long half-lives and potential risk of CNS depression in infants, though studies show low rates of clinically significant side effects with careful use of shorter-acting ones. SSRIs like sertraline and paroxetine are often preferred for postpartum depression due to lower milk levels and fewer reported side effects in infants compared to others. We mentioned dopamine antagonists like metoclopramide and domperidone can stimulate milk production, while ergot alkaloids like bromocriptine suppress it. Newer oral anticoagulants like apixaban often lack sufficient safety data in breast milk and may not be recommended currently. Radioactive agents used for diagnostics may require temporary pumping and discarding of milk for a specific time frame, or even preclude breastfeeding altogether depending on the isotope. And critically, illicit substances readily enter milk and pose a high risk of serious immediate adverse effects, sedation, apnea, even death, and unknown long-term risks. So breastfeeding is universally not recommended with their use.
And what about maternal illnesses or infections? How do they impact breastfeeding decisions and safety? This must come up frequently.
It does. And it's another complex area requiring careful, individualized assessment and often collaboration with medical providers. For human immunodeficiency virus, HIV infection, while transmission via breast milk is well established, exclusive breastfeeding has actually been shown to lower the early first 6 weeks risk compared to mixed feeding in low-resource settings where safe alternatives aren't available, and replacement feeding carries high mortality risks. However, the risk persists as long as breastfeeding continues. In developed countries, if safe alternatives to breast milk are available and sustainable, HIV-infected women are generally advised not to breastfeed to eliminate the risk of transmission. For varicella-zoster virus, chickenpox, most mothers have immunity. If the mother develops chickenpox, she and the baby can usually breastfeed and remain together if appropriate isolation precautions are taken and no skin lesions are on the breast itself. However, if she develops chickenpox within 5 days before delivery or up to 48 hours after, the infant needs varicella-zoster immune globulin, VZIG, and the mother should delay direct breastfeeding until her lesions are crusted, pumping and discarding milk in the interim to maintain supply. Cytomegalovirus, CMV, is a prevalent infection often found in human milk. Transmission through breast milk is documented, but typically does not result in serious illness in healthy, full-term infants. There is, however, significant concern for serious illness in premature and very low birth weight infants.
Okay.
The rubella vaccine virus can pass via maternal milk lymphocytes to the infant, resulting in transient serum antibody responses in the infant without actual illness. A fascinating example of passive immunization. For hepatitis B, HBV, infants born to HBV-positive mothers can breastfeed safely if they receive hepatitis B immunoglobulin, HBIG, within 12 hours of birth and the full HBV vaccine series. Thyroid disorders like postpartum thyroiditis, causing fatigue, depression, anxiety, and hyperthyroidism, weight loss, nervousness, generally do not affect the ability to lactate, but they can profoundly impact the mother's ability to cope. Proper medical management is key. However, Sheehan syndrome, a rare but severe pituitary disruption, panhypopituitarism, usually caused by severe postpartum hemorrhage, typically results in complete lactation failure. Conversely, women with prolactinomas, pituitary tumors that stimulate prolactin secretion, can generally breastfeed without restriction, although medical monitoring is often recommended.
That's a lot to consider across various health conditions. What about the impact of previous breast surgery, or even something as serious as a breast cancer diagnosis during lactation?
Breast surgery or mammoplasty, whether augmentation or reduction, can indeed impact breastfeeding potential. The ability to breastfeed successfully depends heavily on the specific surgical technique used, particularly whether crucial neural pathways to the nipple were severed and the amount of glandular breast tissue removed or altered. Full breastfeeding is generally possible after augmentation, assuming nerves and ducts are intact, but it's often less likely after significant breast reduction surgery, where supplementation is frequently required. Preoperative counseling is absolutely crucial, informing women about the possible effects and the inherent unpredictability of breastfeeding success after such procedures. If supplements are needed, feeding tube devices can be used to allow the baby to continue suckling at the breast. Here's a powerful and often surprising clinical insight. Infant rejection of a breast without any apparent reason, where a baby suddenly refuses to nurse on one side, can occasionally be an early warning sign of breast cancer in the mother, prompting further medical investigation.
Wow, that's important to know.
Yes. If breast carcinoma is diagnosed during lactation, breastfeeding should be interrupted immediately and treatment begun. All chemotherapeutic drugs cross into milk and are potentially toxic to the infant, so women receiving chemotherapy should not breastfeed. Finally, lifestyle factors like smoking are highly detrimental, negatively affecting milk ejection, overall milk volume, infant weight gain, and the duration of breastfeeding. Alcohol consumption also inhibits the milk ejection reflex and reduces the amount of milk the infant consumes during and after exposure.
Our discussion today has been heavily geared towards the IBCLC exam, and understanding the role and responsibilities of the IBCLC is just as vital as the science itself. Let's take a moment to specifically understand the scope and ethical considerations of this crucial role.
That's a vital point. IBCLCs are not meant to provide optimal care in isolation. The care of breastfeeding parents and children is a perfect example of the critical need for a collaborative, interdisciplinary team approach. Nurses and physicians are powerful allies, particularly when they've received adequate training and support in lactation themselves. Regarding avoiding civil liability, which is a practical concern, it's critical for lactation support providers to carry professional liability, malpractice insurance, covering all practice settings. It provides crucial legal counsel if litigation unfortunately occurs. It's also paramount to stay rigorously up to date on new research findings and clinical practices by consistently reading current articles, networking with respected colleagues, and attending conferences. The field is always evolving.
So an IBCLC needs to be constantly learning and connected to their professional community. Lifelong learning is key.
Absolutely. And the practice of parent-centered care is non-negotiable. This means meeting each person's unique needs and supporting their informed choice after they've been offered comprehensive, evidence-based information. A key insight here is that people are far less likely to pursue litigation when they feel they were treated with respect, listened to, and given sufficient information to make an informed decision about their care. Thorough documentation of all assessments, care plans, interventions, the rationale behind those interventions, and any updates is essential not just for legal protection, but to verify excellence in care and facilitate communication with other providers. And critically, an IBCLC must know their limits and refer to someone else if the situation calls for expertise, diagnosis, or prescriptions beyond the IBCLC's defined scope of practice.
Like diagnosing mastitis or prescribing medication.
Exactly. An IBCLC doesn't diagnose mastitis or prescribe antibiotics. They assess, support the mother with comfort measures and feeding strategies, and refer promptly to the appropriate medical provider for diagnosis and treatment. Collaboration is key. This all ties into the core ethical principles of the profession, including the impartial reporting of content, avoiding taking sides on sensitive or politically charged topics related to infant feeding, and strict adherence to the International Code of Marketing of Breast Milk Substitutes, which is designed to protect breastfeeding from inappropriate commercial interests and ensure parents receive unbiased information.
Now, for the moment of truth. We've covered a vast amount of material on mammary development, breast anatomy, and physiology, all essential for the IBCLC exam. It's time to put that knowledge to the test with some IBCLC-style multiple-choice questions. Listen carefully, think through the options based on our deep dive, and then our expert will break down the correct answer and explain why it's the best fit, along with why the other options are incorrect. This is how you really solidify your understanding.
These questions are designed to mimic the complexity and nuance you'll encounter on the IBCLC exam, encouraging you to apply the comprehensive understanding we've gained. Remember, it's not just about knowing the right answer, but understanding why it's right and why the others miss the mark. Let's begin.
Question 1. The basic secretory units of the mature glandular tissue in the breast where milk is actually produced are known as A, ducts, B, myoepithelial cells, C, alveoli, ligaments of Cooper.
Okay, the correct answer here is C, alveoli. Remember, we described the alveoli as those tiny grape-like clusters. They are the fundamental sites of milk synthesis. Ducts A are the transport tubes, myoepithelial cells B are the squeezer cells around the alveoli, and Cooper's ligaments D provide structural support. So C is the milk factory.
Question 2. Which nerve supplies the greatest amount of sensation to the nipple and areola, and its severance, for example during surgery, could lead to a significant loss of sensation? A, second intercostal nerve, B, third intercostal nerve, C, fourth intercostal nerve, D, sixth intercostal nerve.
The answer you're looking for is C. Fourth intercostal nerve. We emphasized its critical role and its specific entry points, 4 to 5 o'clock on the left, 7 to 8 o'clock on the right. Severing this nerve can significantly impact sensation and potentially the letdown reflex. The other intercostals contribute, but the fourth is key for this specific area.
Question 3. The proliferation of ducts and the glandular system during mammogenesis, the overall breast growth, primarily occurs under the influence of which hormones? A, prolactin and oxytocin. B, estrogen and progesterone. C, growth hormone and thyroid hormone. Insulin and cortisol.
The correct choice is B, estrogen and progesterone. Mammogenesis, the structural development, is primarily driven by these two. Estrogen focuses on the ductal system, plumbing, progesterone on the glandular tissue, milk units. Prolactin and oxytocin A are for making and ejecting milk later. The others, C and D, play general roles but aren't the primary drivers of this specific breast development.
Question 4. The initiation of milk synthesis that begins remarkably early, specifically in mid-pregnancy, is referred to as A, galactopoiesis, B, lactogenesis stage 1C, Lactogenesis stage 2D, mammary involution.
The correct answer is B, lactogenesis stage 1. This stage is precisely defined as the initiation of milk synthesis starting mid-pregnancy, where cells differentiate and begin producing early milk components. Galactopoiesis A is maintaining established supply. Lactogenesis 2T is the onset of copious milk post-birth. Involution D is the gland shutting down.
Question 5. The primary hormonal trigger for the dramatic onset of copious milk secretion, which is lactogenesis stage 2 occurring after birth, is A, a significant increase in maternal prolactin levels, B, a rapid drop in maternal serum progesterone levels, C, the release of oxytocin from the posterior pituitary, D, the infant's first suckling at the breast.
The answer is absolutely B, a rapid drop in maternal serum progesterone levels. This is the key trigger. The removal of progesterone's inhibitory effect after placental delivery allows prolactin to fully activate copious production. While prolactin needs to be high, A, and suckling maintains supply, D, the trigger for L2 onset is progesterone withdrawal. Oxytocin, C, is for letdown.
Question 6. During lactogenesis, stage 2, a crucial cellular event is the closure of tight junctions between alveolar cells. This primarily leads to A, increased passage of substances between cells, B, a shift from autocrine to endocrine control of milk production, C, a significant decline in milk lactose levels, D, cessation of substance passage between alveolar cells, directing flow through them.
The answer is D, cessation of substance passage between alveolar cells directing flow through them. Sealing those gaps, tight junctions, stops the leaky paracellular pathway and ensures milk components are synthesized and secreted through the cells. This leads to a rise in lactose, opposite of C. Control shifts from endocrine to autocrine, opposite of B. Passage decreases between cells, opposite of A.
Question 7. Which statement is true regarding maternal prolactin levels during lactation, considering its daily rhythm and long-term presence? A, levels are generally highest during daytime feeds. B, they remain elevated only for the first 6 months postpartum. C, more than 8 breastfeedings per 24 hours can prevent their decline before the next feeding. D, they are directly proportional to the amount of milk yielded by the mother.
The correct statement is C. More than 8 breastfeedings per 24 hours can prevent their decline before the next feeding. We discussed the circadian rhythm, higher at night, so A is wrong, the long-term elevation, B is wrong, and the fact that levels aren't directly proportional to yield once established, D is wrong. Frequent feeding keeps levels more consistently high.
Question 8. The hormone oxytocin primarily causes what specific action during breastfeeding? A, stimulation of milk synthesis. B, contraction of myoepithelial cells leading to milk ejection. C, growth of the mammary glandular tissue. D, suppression of ovulation.
The primary action of oxytocin here is B, contraction of myoepithelial cells leading to milk ejection. That's the letdown reflex. Prolactin stimulates synthesis. A, estrogen progesterone drive growth. Prolactin primarily suppresses ovulation. D.
Question 9. The corrugated transverse folds, known as rugae, on the infant's anterior hard palate serve what crucial purpose during feeding? A, to create a vacuum for swallowing. B, to seal off the nasal cavity during sucking. To assist the newborn in holding the breast during sucking. D, to filter milk before swallowing.
Correct answer is C, to assist the newborn in holding the breast during sucking. Those rugae provide essential friction and grip, helping the baby maintain hold of the breast tissue. The tongue-jaw create vacuum, the soft palate seals the nose, B, and there's no filtering mechanism like D.
Question 10. By what gestational age can preterm babies typically coordinate the suckle-swallow-breathe cycle at the breast, a significant developmental milestone for feeding? A, 24 weeks. B, 28 weeks. C, 32 weeks. D, 36 weeks.
The answer based on our sources is B, 28 weeks. While suckling starts earlier, the coordination of suckle-swallow-breathe typically emerges around 28 weeks gestation, making it a key point for assessing readiness for oral feeding attempts.
Question 11. An optimal latch for breastfeeding is characterized by the baby's nipple tip resting deeply in the mouth and the baby's lips being positioned in what way? A, pulled inward tightly. B, slightly puckered. C, flanged outward. D, retracted behind the gums.
The correct description is C, flanged outward. Think fish lips. This indicates a wide gape and a good seal on the areola, preventing nipple compression. Lips pulled in, A, puckered, B, or retracted, D, are all signs of a potentially shallow or problematic latch.
Question 12. How does the fat content of human milk typically change throughout a single breastfeeding session from beginning to end? A, it remains constant regardless of breast emptying. B, it decreases as more milk is taken from the breast. C, it increases more steeply as more milk is taken from the breast. D, it is not affected by the degree of breast emptying.
The correct answer is C. It increases more steeply as more milk is taken from the breast. Fat globules adhere to alveolar walls and are released more towards the end of a feed as the breast empties. So, hind milk is richer in fat than fore milk. It's definitely not constant A or unaffected D, and it increases, not decreases B.
Question 13. In mature human milk after the initial transitional period, the whey to casein ratio is approximately
50.
90.
The typical ratio in mature human milk is B, 60.40. This balance provides easily digestible whey proteins along with casein. 90.90A is more like early colostrum transitional milk. 50.50C might be seen in very late lactation.
Right.
10.9D is more characteristic of bovine milk.
Question 14. Which specific component of human milk is known to help block antigens from attaching to the gastrointestinal tract epithelium, thereby preventing pathogen attachment and acting as a gut protector? A. Lactose. B. Casein. C. Oligosaccharides. D. Lipase.
The answer is C, oligosaccharides. These complex carbohydrates act as decoys or directly block pathogens from binding to the infant's gut lining. Lactose A is energy, casein B is protein, lipase D digests fat. Oligosaccharides are key for this specific protective function.
Question 15. Breastfeeding is consistently associated with a reduced risk for which of the following conditions in infants and children? A. Otitis media. B. Malocclusion. C. Childhood cancer, e.g. Hodgkin's disease. D. All of the above.
The correct answer here is D, all of the above. Our discussion covered the protective effects against ear infections, otitis media, the benefits for oral development reducing malocclusion, and the associations with reduced risk for certain childhood cancers. Breastfeeding offers broad protection.
Question 16. A persistently high breast milk sodium level on day 3 postpartum can be a significant indicator of what specific issue? A. Excellent milk production and established supply. B. Impending breastfeeding problems and lactation involution. C. A healthy and smooth transition to mature milk. Adequate infant intake and efficient milk transfer.
The correct answer is B, impending breastfeeding problems and lactation involution. High sodium reflects those open, tight junctions, meaning lactogenesis 2 is delayed or stalled. It's a warning sign. It definitely doesn't indicate excellent production, A, a healthy transition, C, or adequate intake, D. Quite the opposite, usually.
Question 17. Which is a primary recommended use for ultra-thin silicone nipple shields in clinical practice? A, as a permanent solution for low milk supply. B, to induce lactation in adoptive mothers. C, to facilitate latching in infants with oral anomalies or nipple challenges. D, to consistently increase overall milk volume pumped.
The primary recommended use is C, to facilitate latching in infants with oral anomalies or nipple challenges. They are a tool to overcome specific latch difficulties, like with flat inverted nipples or anatomical issues in the baby. They are not a solution for low supply itself, A, not used for induction, B, and don't inherently increase pump volume, D, though they might help if poor latch was limiting emptying. They should be used temporarily with guidance.
Question 18. When considering medications for a breastfeeding mother, which characteristic of a drug would generally indicate a lower risk of adverse effects to the infant? A, long half-life in the mother. B, high oral bioavailability in the infant. Poor oral bioavailability in the infant. High central nervous system penetration.
The characteristic indicating lower risk is C, poor oral bioavailability in the infant. If the baby absorbs very little of the drug from the milk that enters their gut, the systemic exposure and risk are lower. Long half-life, A, high bioavailability, B, and high CNS penetration, D, generally indicate higher potential risk or exposure for the infant.
Question 19. What is the general impact of gradual maternal weight reduction, such as losing 4 per 5 pounds per month on lactation? A, it invariably decreases milk supply. B, it has no deleterious effect on lactation. C, it is only possible with very low caloric intake. It requires stopping breastfeeding temporarily.
The general consensus from our sources is B. It has no deleterious effect on lactation. Gradual, sensible weight loss through moderate diet and exercise is safe and doesn't negatively impact milk production. It doesn't invariably decrease supply. It doesn't require extreme dieting, C, and certainly doesn't require stopping breastfeeding, D.
Question 20. Which intervention is strongly recommended immediately after birth to reduce the risk of hypoglycemia or low blood sugar in a newborn, especially for at-risk infants like those of diabetic mothers? A, immediate formula supplementation. B, delaying cord clamping and encouraging skin-to-skin contact with unrestricted access to the breast. C, initiating formula feeding immediately and frequently. Frequent separation of mother and infant for rest.
The strongly recommended preventive approach is B, delaying cord clamping and encouraging skin-to-skin contact with unrestricted access to the breast. These practices help stabilize the baby's transition, maintain temperature, and facilitate early, frequent colostrum intake, all crucial for preventing hypoglycemia. Formula AC may be needed therapeutically, but isn't the primary prevention strategy, and separation D is counterproductive.
What an incredible deep dive we've had today. We've traversed from the microscopic cellular changes within the breast to the profound macroscopic impact of human milk on infant health and development, even touching on the vital ethical role of the IBCLC. It truly highlights the complexity and sheer biological elegance of the human lactation system.
Indeed. And hopefully for you listening, especially if you're preparing for the IBCLC exam, this foundational understanding feels like, well, a superpower. Mastering these biological details empowers you to provide truly informed, nuanced, and compassionate care, recognizing subtle cues and intervening effectively. It's an ongoing journey of learning that makes a profound difference.
And as you carry this knowledge forward, maybe consider this provocative thought for your own continued growth. Considering the sheer biological brilliance embedded in human lactation, what deeper ethical responsibilities do we, as informed professionals, bear in ensuring every family has the knowledge and support to fully understand and navigate this profound, life-giving journey, whatever their choices may be?
And building on that, how can we continuously foster that knowledge and critical thinking within ourselves and our communities? Continue your own deep dives. Keep asking questions. That relentless pursuit of knowledge and critical thought are really the hallmarks of a truly impactful professional in this field.
Thank you for joining us on the deep dive. We encourage you to apply this newfound knowledge, ask further questions, and seek additional resources as you continue your learning journey.